Broadcast is now starting. All attendees are in listen.
All right, for everybody who's attending, I just want to say thank you for coming today and joining us. We appreciate you taking your time. Everybody's got busy schedules. For the attendees, just to let you know that your microphones will be muted throughout the presentation. If you have any questions, there will be time at the end of the presentation for questions. And you can do so by just typing your question into the chat box for us. And we'll go from there. And I will pass it over to Dr. Green to introduce Dr. Beckett.
Thanks, Andrew. And thanks everyone for coming. This is our first webinar of the year, and with COVID, it's been a first webinar in a long time. So we're really happy to have Andrew Beckett join us today from Toronto. Andrew's a previous trainee here in Halifax, and I know he enjoyed his time. Right, Andrew? Yeah?
Well,
yeah.
Except I can't talk about it though. So
that's right. So Andrew is a lieutenant colonel in the Royal Canadian Medical Services and serves as a trauma surgeon and critical care physician. He is a trauma advisor to the Surgeon General and the Chief of General Surgery in the Canadian Forces. He has served on multiple military missions overseas. He's also a trauma surgeon and the current medical director of the trauma program at St. Mike's Hospital in Toronto. His research interests include massive transfusion and resuscitation in the austere setting, combat casualty database management, and military simulation training. He's currently an associate professor of surgery at the University of Toronto. And we're really happy to have Andrew. With COVID challenging us on multiple levels, I really wanted Andrew to speak on how they've dealt with the COVID trauma patients in St. Mike's, and to share their experiences and some tips and tricks to help us out here in Nova Scotia. So I'm going to hand it over to Andrew. Andrew, thanks a lot for joining us.
Okay, thanks, Rob. It's great to be back in Nova Scotia and Maritimes, even virtually. Rob asked me to give this talk on, trauma and COVID-19, and so hopefully I'll give you a bit of my perspective on this. As disclosure, I'm not, an infectious disease expert, or any kind of IPAC expert, but hopefully this will give you a sense of how we manage things here. Trauma in the time of COVID-19. I put this slide up. This is in the left-hand corner there. That's a piece of graffiti I have to walk by every day to my place here, office here. But, trauma in the time of COVID-19, I think this slide sort of was reminding me to say that, trauma is not the big thing right now, and I think we had to learn that. So in the grand scheme of human experience, pandemics carry off more people to the grave than trauma does, and even war. So pandemics are the big killer, and so that's a big thing that we had to learn here, is that trauma, it's a small thing that's happening in the setting of something much greater that's impacting society. And I think when I got here in Toronto, I just moved here in March 2020, and had lots of plans to set up new programs, get things set up. I had lots of meetings lined up, and shortly after I got here, everything started getting canceled. And so with trauma care, we were trying to maintain our capability and adapt to the changing situation. So that's a lot about what this talk is about, and try to keep things in perspective here. Speaking of perspective, there, the last major pandemic was in 1918, called the Spanish influenza pandemic. About 50 million people died during that event, and probably that's an underestimate, probably more like 100 million people. And over 50,000 Canadians died from this. And like everything, is these public health measures, they can be complicated by other social events that are ongoing. And at the time of the 1918 pandemic is something that Halifax remembers well, is the Great War. The Great War was ongoing, and there was a major global effort, fighting this conflict with this large conflict being centered mostly in Europe. And of course, Halifax was a major port of embarkation for both troops and supplies overseas, and leading to of course, the Halifax explosion, which was just very well remembered in Nova Scotia. That was a tremendous loss of life. So, the pandemic was sort of overshadowed by things going on globally, and and policymakers had to make a decision on what was more important, was the pandemic or the war in Europe. And most policymakers decided that the war is more important and kept concentrating people, speeding up production in factories, and doing all the other things necessary to bring people together to unite in a common effort in the war overseas. So in 2020, when things started shutting down in the pandemic, because that's what you want to do in a pandemic, is you want to slow society down. You want to shut things down and stop people moving around and traveling, and you want to really limit the mobility of people, and you want to keep people home and away from other people. And I could say, in the early days, when the initial shutdown, when I was just coming to my office and looking at a blank agenda sheet, or my calendar was completely white space because there's nothing happening. I think it was a really eerie experience in Toronto, and those of you who have come to Upper Canada and walked down Yonge Street at rush hour, I can say the street was completely empty. There was no traffic. There was nobody walking on the street. It was a very eerie experience. Almost many people refer to it as a zombie apocalypse. And I think the experience of the pandemic here was, it was such a disruptive force in so many people's lives, including mine. And I came here with all these big plans, and then I didn't know what I was doing. But I think as a new leader coming into an organization, when you start at any new job, you really don't know what you're doing or what's going on. So it kind of worked in my favor, because nobody knew what was going on during the early days of the pandemic. And because some of my military background, I was used to dealing with a lot of uncertainty and having to change the plans every 5 minutes. So I probably didn't look like as much as a fish out of water than I otherwise would.
Sorry to interrupt, Dr. Beckett.
So I think, yeah.
I just want to let you know that your screen's
Go ahead.
Sorry to interrupt. I just wanted to let you know that your screen, you went out of the full screen. So we're seeing your whole presentation.
Okay, so went out.
Yeah, just to let you know.
My whole presentation. Oh, it went.
You went out
Okay. Let's try that again.
of. Sorry.
All right. It's all right. This is going to be fun, I guess. All right, we'll try this again. All right, does that work?
Sorry, we just see you.
Okay. Another window. Application. Okay, you guys see that?
No, we just see you.
Okay. Try one more time. Can you guys see that? No.
Nothing yet.
It said stop. Nobody sees your screen. I'm pushing show. I'm clicking the.
If you want to send Andrea or I your slide, and then if you want to keep talking, I can see if I can share my screen with your slide presentation so that you can keep going. Does that work for you?
Sure. Okay. Okay. I guess keep talking here. Okay, is that any better? No. Okay. So so this talk is a lot about the pandemic in its early days and how we had to flex and accommodate and adapt to the changing pandemic. And I think everybody's very jealous of how things played out in the Maritimes, especially with your great public health measures and the Atlantic bubble. And every meeting that I would go to, people would say, "Is like, why can't we do it like Atlantic Canada? Why is our politicians so stupid here? And why why is this happening here?" But I think there's a lot of luck to it. I think in some ways, some parts of Toronto got very unlucky, and some parts of the rest of Canada are experiencing some bad luck right now. And one of the things to realize is, it's that this virus doesn't care. It doesn't really have any political affiliations, and it's going to do what it's going to do. And if you let down your guard, it's gonna take advantage of that. So you have to think is, well, could it happen? Could it happen again? Could it happen anywhere? I think this is probably in order to help you if it happens in Nova Scotia again. I had some great pictures here of the Halifax Infirmary and St. John, New Brunswick, but I guess you can't see that now. Unless this is working again. Do you guys see that? No. Okay. So planning it, many of us had to plan how we're going to continue to provide trauma care seamlessly during the pandemic. But in a lot of ways, it's not possible due to this other major event that was happening. And a lot of discussions focused around the critical care capacity of the province and what we were going to do. So very early on in the pandemic, there was discussions around triaging patients. Now, many trauma centers across the country are pretty aggressive when they're having people coming in with a traumatic arrest. And there was discussions whether we should be doing this anymore during a pandemic. And there was discussions across the country and in the U.S. whether especially for blunt traumatic arrests, we even be doing those cases during the setting of the pandemic. And I think many centers, we really started following the recommendations that there really has to be an indication to go ahead and do an ED thoracotomy for somebody who has suffered a traumatic arrest, and not to overwhelm the capacity of ICUs that already have tenuous resources due to the number of patients within ICU. So these were early days, and I think talking about things that we were going to do. At the same time, there was other epidemics ongoing. Notably within Canada, in some places more than others, the epidemic of opioid abuse and overdoses, and that was exacerbated by the pandemic. And the other epidemic that was ongoing in Toronto, which still is happening, is the epidemic of gun violence that's running through the city. In fact, by December 22nd, 2020, the only time that it was stated was the worst was 2019. So by December 22nd, 2020, 214 people have been killed or wounded by gunfire in Toronto. Toronto does have a large problem with firearm violence. And in fact, Toronto is by far outstripping the rest of Canada with the number of fatal and non-fatal incidences of gun violence. And so, Toronto it's the fourth largest city in North America, so it's got big city problems. This is all from Statistics Canada. The rate of the population keeps growing up here, and by probably 2030, the Greater Toronto area will be about 6 million people, and so these inner city problems keep coming up. So this was all ongoing before the pandemic dropped on us. So one thing that we've always said in the military is no plan survives contact with the enemy. So we had all these great plans, what we're going to do, how we're going to manage trauma patients, how we're going to triage people, how we were going to adapt to the trauma care in the pandemic area, and then we had to brace for changes. One thing they also say in the military is, the plans are worthless, but planning is everything. So really sitting down and going through all what you do know, making plans for contingencies, making decisions on the resources, really lets you know what resources you have to operate within a pandemic setting, and who you need to call, and it's meeting lots of people and learning the whole range of assets that you do have to meet the changing situation. But at any time, you have to be ready to throw away the plan and make a new one based on the changing situation. And one thing we did learn was that it's very obvious that the pandemic versus trauma care are right angles to each other. In trauma care, you want to speed things up right from the pre-hospital side, right to the trauma bay, and right to the operating room. But when you're doing things with a pandemic, an infectious disease, you want to slow things down. You want to screen the patients, you want to have your PPE on, you want to decide if there's going to be an aerosol generating medical procedure. So you want to really slow things down. But in trauma care, you want to speed things up. And so these things are completely at right angles to each other. They don't really go together. And so how do you balance that? Well, it's near impossible, because you've got somebody that comes in that's multiple gunshot wounds in the chest, and you're trying to put your PPE on, and you have a PPE officer that's trying to get you to slow down while you're donning your PPE, and you're trying to get in there to deal with this very sick patient. So it's very difficult to find a balance in this. And that's some of the initial things that we found, was getting people to slow down because the priorities were changing. And again, one of the top priorities being that, protecting our staff and our trainees from potential exposures. About this time, the Trauma Association of Canada and other organizations started releasing messages and guidelines about how to provide trauma care within the setting of COVID-19 and an infectious disease pandemic. And I think these were helpful, but the problem, as I'm sure many of you experience, is every day there's a new guideline coming out as we learn new information, and there's new fears being raised every day, and with more communication required to counteract that. So people were getting drowned in a deluge of new guidelines and updates. So that was one of the issues that for leadership is, trying to communicate simply and trying to give folks confidence that the advice that was given was rational and sound, but understanding that the messages were changing from authorities every day. And so I think that was one of the most challenging things, is trying to give people some sense of comfort with the information that was being passed down, and then having to change that the next day as some more information came in. I remember one setting we were talking with the orthopedic surgeons, who were very concerned about the exposure to aerosolized blood products during orthopedic surgery, such as things as drilling and using orthopedic saws, etc. And so they're very concerned about exposure to these agents. And because of my involvement with Canadian Blood Services, I knew that blood was not even being tested for COVID-19. And so I passed that on, and then people at the meeting got very concerned that that we didn't even know whether the blood products that we were getting had been tested for COVID-19 or not. But then it came down that COVID-19 is not really a live virus in blood products, but there was all this conflicting information coming around, and it was often quite difficult to reassure people that they were being protected and that they were getting the right information at the right time. One of the big topics that always came up, as I alluded to, was the aerosol generating medical procedures and the requirements for N95 respirators, and what were AGMPs. And I think everybody, rightly, identified that intubation and extubation were high risk settings for this, as well as bronchoscopy, tracheostomy, tracheal suctioning, and CPR with bag mask ventilation, and other things would come up. Well, what about thoracotomy? What about chest tube? What is the risk of a chest tube placement? And in fact, what is the risk of laparoscopy for trauma cases in terms of this? So the issues around airway generating medical procedures, which I think have been fairly nailed down, and they're limited now, not including everything like laparoscopy, because that was one of the big fears early in the pandemic, that procedures like acute operations for a laparoscopic appendectomy would be an aerosol generating medical procedure. So at our institution, like everywhere else, we did have COVID-19 intubation protocols. And I think this is, the most difficult one to to sort of regulate as a trauma medical director, because, you know, as a trauma medical director, I'm not in the trauma bay all the time, and I have to delegate authority to the trauma team leaders to ensure not only care of the patient, but also now to protect the safety of the trauma team members and anybody else that's walking into the trauma bay. So this was an extra responsibility that was downloaded onto the trauma team leaders, which you had to in this setting, because as the medical director, you know, I'm not there all the time, and these guys, as the trauma team leaders, they have to be responsible for this. So one I think the smartest things is, you know, if you don't have to be in the trauma bay during an intubation during this time of COVID-19, you know, don't be there. Like, you know, and the other thing is, there was an initial, you know, discussion, because in our trauma base, it was the ventilation was set up as an operating room with positive pressure to keep aerosolized pathogens out, and you know, so we could not switch that to negative pressure in our trauma bay. And so initially, I had some of the trauma team leaders, they were so uncomfortable intubating somebody in a positive pressure environment that they were trying to move them, seriously ill trauma patient, to a negative pressure room, which was, you know, not helpful. So, you know, because of the size of the negative pressure rooms, etc. So, you know, I think the first thing is, if you don't have to be around during an intubation, don't be there. Anybody that's going to be there, you needed to have full COVID-19 PPE, including N95, face shield, gown, goggles, extended length gloves. And the intubation plan prioritized the use of a glide scope, RSI, and avoiding manual bagging, also including a viral HEPA filter, and inline suctioning only. So we did have a PPE officer that would assist in the donning and doffing of PPE during and after intubation procedures. But again, you know, all these things are put onto the trauma team leader, who is also busy with other matters in their mind, including, you know, care of the patient, most importantly, and where the patient is going. So TTLs, you know, were responsible for making sure that we kept the numbers in the trauma bay limited to the essential personnel only. But what we did do is we set up a viewing room across the hall with cameras and a live video feed. So people that did want to watch the trauma or thought that they weren't needed at that time, they could watch the video with some audio and get a sense of what's going on. So we would initially have anesthesia. They would be watching the video, and they would be then called into the room to see the patient. So, you know, many institutions pick these up, and at the ATTAC, Trauma Association of Canada, we posted these on our website for general use. You know, and I like this one from the Trauma Services BC, what the principles are being: protect the patient, trying to maintain an acceptable standard of care, manage the risk of COVID-19 transmission, protect the workforce, minimize the contamination of shared spaces, minimize contamination of equipment, preserve critical supplies, anticipate the need for surge response planning, and an ethical approach to rationing. So I think a couple of things that, you know, were important here, and I'll go over this a bit again, is, you know, decanting the trauma base. So anything that didn't need to be in there, we took it out, which of course led to some complaints. You know, minimizing the contamination of equipment by, you know, moving that extra glide scope outside to the room across the hallway. And also preserving critical supplies. As you remember, in the early days, you know, there was we were short supply of N95 masks in particular, and some weeks gowns, some weeks masks, you know, just medical masks. So this was a constant concern. So, you know, the more people you had in the trauma bay, the more burn you were going through with PPE. So, you know, trying to preserve that resource. You know, and I think this led to the rationing of N95 masks in particular. This led to some distrust of leadership because we were trying to save use mass for reuse and possibly reprocessing them, and there was lots of questions whether this was effective or not. And I think not having the adequate PPE supplies in the system really did impact staff morale. So we learned that we have to have these supplies ready for our folks to protect themselves when they're caring for sick patients. Many of the trauma teams, which remain pretty much the same, but again, we would try and not bring in people that didn't need to be there. If this was the person didn't need to be intubated, we'd have anesthesia waiting outside to be called in and ensure that they were present, but they weren't necessarily walking into the room and walking out of the room. So, I think we learned from this that no matter what you think, your plan for trauma care isn't ready for the next pandemic, because we don't know what the next pandemic is going to look like. We don't know what the organism is going to be, and next one, it could be a bloodborne pathogen. So we just don't know. So you have to be ready to adapt your plan as more information is generated. But one thing we did know that I think many of you saw is that viruses are a very determined enemy, and they'll interfere with all your current operations and planning. And every time you try to make a change to your protocol to get around something, it's like, oh well, the virus can do that. And one thing I think we learned that you thought, well, this trauma went badly, because everybody's putting on their mask, and why are we doing this? It's so dumb. And then, the patient would be tested for COVID-19 and they come back positive. So, even that people that didn't look sick and people thought that, people with COVID-19 aren't just walking around in the community getting shot. Well, they were, because, many of the patients that we initially treated, and people were frustrated with all the protocols and saying, well, this is not affecting this population of the people out getting involved in violent interpersonal conflict, don't have COVID because they look too well, but actually they did have COVID. So this was always a recurrent surprise to people until people got used to it. Like everybody could possibly have COVID. So these. The COVID-19, and those of you that are researchers, obviously, I'm sure many of you took advantage of the COVID-19 situation to raise new research questions and to try and find solutions, how to deal with the pandemic. And, just like our institution, like many others, we're able to provide solutions. And one of my colleagues here, João Rezende, he developed an airway dome, so it's like a protected intubation tent to go for COVID-19 patients during intubation. Had a negative pressure with HEPA filters, and so there's a lot of innovation early days as we were learning to adapt to this. I think this particular version went pretty well, but I think most people got very comfortable with using N95 masks and appropriate PPE, and we're able to deal with the situation with PPE versus things like airway tents or intubation boxes, etc. One thing that we learned that, just like certain communities that have a lower social economic status are more prone to suffering from interpersonal violence, these are the same communities that were affected the most by COVID-19. And I'm not sure if you guys can see my presentation anymore. It says it's showing the application now. If you can see it, when we did maps of, the highest increase of in shooting instances and interpersonal violence, these completely, overlapped completely with the COVID-19 distribution. So areas such as Peel, which a large number of our folks suffering from gunshot wounds come from. This had the highest instances of COVID-19 as well. So it's no surprise that, SES, both in infectious disease and trauma, I mean, these are the same populations, same communities that are being affected. The trauma volumes during the lockdown, this was the greatest injury prevention program that in the history of mankind, basically, because very early in the pandemic, our trauma volumes just plummeted. With the stay-at-home orders, there was very little going on, and the things that Toronto is well known for is pedestrian struck, and all the MBCs that were happening, those really plummeted. And the interpersonal violence and things like suicide attempts persisted, but a lot of the things that we see normally here is we see a lot of cyclist deaths and pedestrian struck deaths, but those really decreased during the pandemic. And you can see here, if you guys can see this, is just as a comparison, in fiscal year 1920, we had about almost 1,200 trauma team activations, and that decreased to the 900s in the fiscal year 2021. So decreased by about a quarter in 1 year. So a massive dip in the amount of injury we're seeing here, and this happened at Sunnybrook as well as St. Michael's in Toronto. You can see here is early in the pandemic. If you look at the fiscal year April 2020, we had 156 trauma patients reviewed, and that's compared to we're right back up in April of 2021 with 188. By about, I'd say about July 2020, we're getting back up to some normal numbers. But definitely we did see, during those early days of the pandemic, we did see a massive dip in the number of trauma patients we're seeing. I think these slides got a little bit out of order, but anyways, this is this slide where COVID-19 was happening in Toronto, the Toronto area. And again, this is showing that the amount of gun violence, it lines up almost exactly with these areas of increased COVID-19 cases. Interestingly, in Toronto, there's area, if you can see this, where the COVID-19 vaccination rates were very high, and these were all in sort of more affluent neighborhoods, and these are the areas where the gun violence is the least prevalent. Some other research has been done that's from about COVID-19 and the prevalence of injuries. In the pediatric injuries, the number of those cases dropped. Injury-related emergency department visits at pediatric centers decreased by 62%. And this is a Montreal-based study. In the orthopedic world, the Canadian Orthopedic Experience, they also saw large decreases, especially with fewer ankle fractures, because people weren't out doing anything. They weren't out playing soccer or hockey or whatever. But interestingly, there was no change in the incidence of polytrauma, hip fracture, or wrist fracture during the pandemic. And certainly, we did see decrease of all these things like ankle fractures, but we did see the sort of sustained polytrauma cases. And the only injury mechanism that we did see here was in the mechanism of a motorcycle collisions. And so in 2020, motorcycle-related deaths were up 300%, and we did see a lot of very severe motorcycle collisions. And the hypothesis was that people have more time at home, they're a bit bored, the roads are wide open, and so it's easier to go faster on your motorcycle. And we did see a lot of these really tragic motorcycle accidents. As well as in Canada, in Toronto, we did see collision rates really drop during the lockdowns, as there was very little traffic on the road as people were abiding by the stay-at-home orders. So this type of evidence shows that, you know, if you enforce very strong measures, you can reduce the rates of the traumatic injury. We looked at our gun violence rates during the pandemic, and they really didn't increase. Here, they maintained fairly steady, but you know, as we were projecting, or at least we're worried about that there could be a big upsurge in violence as the economic lockdowns were lifted, and like in the States, where you know there was just a massive escalation in the number of gun-related incidents as compared to the pre COVID-19 statistics. So, you know, the U.S. showing that the gun violence increased 30% during the pandemic. Chad Ball, who many of you know, out in Calgary, they reported increase in blunt assaults. They decreased blunt assaults, but it increased in penetrating trauma, and it was penetrating trauma increases were mostly due to gunshot wounds during their COVID-19 experience. So, you know, just a couple of points about leadership in the pandemic is, you know, I think you really have to own things and take responsibility for things when things go wrong, and you know, and I think you have to be humble. It's like, you know, we were all making decisions based on very limited evidence and trying to do the best we could. And we had to be flexible. We, you know, if you couldn't completely hold to any one plan because it was going to change tomorrow. And so you had to really believe that there was no bad teams, there was only bad leaders. You know, believe in what you're doing. And I think, you know, all of us in the trauma community want the best for our patients, and check the ego. And also, you know, cover and move, meaning you have to delegate a lot of responsibilities so you can get things done, and vice versa with your other colleagues. Try to keep the plans simple. And that's what we tried to do in the trauma bay, keep the plans as simple as possible. And again, you know, trying to prioritize what's important and then execute that. Not everything was about, you know, trauma during the pandemic, and it was a very small thing. And, you know, some other things we had to look at doing is we were placing lots of chest tubes in the ICU. At one time, the trauma program, we were going to be asked to help prone patients in the ICU. This was in April when the system looked like it was becoming destabilized and they were running out of resources. So we were going to help with proning patients. Also decentralized command, you know, and I think one thing in the pandemic we learned that not everybody has to be at work all the time. You can do all your meetings by Zoom or by Microsoft Teams, and you know, and plan. And again, you know, not make a plan and stick to it, but you know, planning is everything, but the plan is really worthless, and you know, you have to adapt the plan every day. So, you know, leading up and down the chain of command, you know, sometimes as a leader, you have to be a follower and listen to the folks under you because they know what actually is going on. You have to be decisive and have to live with a lot of uncertainty, which many of us were uncomfortable with. But, you know, living with uncertainty in a pandemic is I think, is what you have to do. You have to live with the uncertainty because we don't know what tomorrow is going to bring. And being disciplined, you know, you have to be disciplined in terms of what you're doing in your organization, and when you're disciplined, that frees up bandwidth to try new things and to continue on exploring the fringes of new operations. So you know, being disciplined of what you have to do, and having a routine frees you up to do other things. So again, you know, the hardest thing for you know, us as physicians and stuff like that is we like doing what we normally do, and we don't like changing that up. And so normal operations where we had patient safety, and then you have education. So, you know, patient safety is a big example. As a patient comes in the trauma bay, needs a chest tube, and The education side is, well, a resident needs to learn how to put a chest tube in a real patient. So this is, I'm going to protect the safety of the patient and allow the patient, allow the resident the education to place the chest tube under direct supervision. So that's kind of some of the normal balances you have in the trauma bay. But then when you're during the setting, as I mentioned, is you have to now balance staff safety and exposure with PPE conservation, and patient safety and education. So you have to now balance all these things in a setting where, you know, there's no vaccine, people were afraid, there's no rapid testing and limitations on PPE. You know, we did have some instances where, you know, had to get involved where some of the anesthesia residents and staff would come down to the trauma bay wearing the Ebola suit. And that didn't make people feel good because, you know, you've got one person wearing an Ebola suit and everybody else is just got an N95 mask on and a yellow gown. So obviously, you know, that wasn't on and we had to address that. And obviously this was not going to be sustainable, you know, if we're going through the Ebola suit every time there was a trauma team activation. So, and you know, here we do probably get you know, at least 3 to 4 trauma team activations, you know, per 24 hours, you know, at least. You know, in the summer it can be up to 6, 12 trauma team activations a day here. So, you know, obviously, you know, you have to make sure everybody's on the same playing field. So somebody walking with a full Ebola suit when everybody else is just wearing an N95 mask doesn't breed confidence. So, you know, we're in the endurance phase of this war against COVID, this long phase, and you know, there's major workplace and social changes that are happening, and where the future's going, you know, who knows. But one thing, you know, I'm sure about it, the changes have been so profound is we're never going back to normal. You know, before COVID-19, it wasn't normal for surgeons to be tweeting about COVID-19 on Twitter all the time and weighing in on public health guidance, but that's now normal. You have surgeons that are always tweeting about COVID-19 vaccination rates and things like that. So, you know, and that persists. So obviously, you know, the world has dramatically changed. And I was talking to Rob Green just before this got started. And last year, the Maple Leafs were winning on a winning streak. And you know, so obviously the world had been flipped upside down. And I think, you know, it's difficult to predict what long-term impacts the pandemic will have on trauma programs. I mean, we're all still going to care for trauma patients. But you know, I think many of us are, you know, expecting some of our, there's going to be some financial pain coming in the future as governments try to recover from the pandemic, and how is that going to affect our plans? Some things will be better because of things like the widespread adaptation of meetings like Zoom and Teams, and for better communication and better education. But there, you know, there's going to be some negative things, and in terms of the future that we're going to have to balance. And you know, one of them is the epidemic of misinformation. You know, with a population, I think early days, you know, the public was very, you know, ready to go along with public health guidance, and so they're, you know, doing what people, the healthcare professionals told them to do. And today, you know, we have people protesting against vaccines and the hospitals and public health measures. And so, you know, I think that makes, when we say, you know, things in the future, like you know, it's not a great idea to ride an ATV with no helmet on. You know, there may be some pushback against those type of messages because people are more resistant to it because of this rise of different information. You know, and I think, you know, to sum up is you know, the Maritimes can really benefit from learning what others have done, and you know, you can learn to counter these threats, both from the, you know, internal trauma programs interest, and also in the outside world and within the hospital and the community. And I think, you know, one thing, you know, people have really succumbed to in the pandemic is that, you know, if you, as Marcus Aurelius said, as a Roman emperor, if an infected mind is far more dangerous pestilence than any plague. and he lived in a plague. One only threatens your life, but the other destroys your character. So no matter what you do, is you have to try to preserve your character and your passion and your raison d'etre for providing good trauma care, and not let some of all this other extraneous influences impact you. So just to sum up, and my apologies for the technological glitches, is these situations are all tests of leadership, and I would say being adaptable is the key. And I would never commit to any one plan, and know what the priority is. In this case, in the COVID-19 pandemic, trauma care has been a lesser priority. But the good thing with trauma care is that we now have a vaccine for COVID-19, but there'll never be a vaccine for alcohol and a motorcycle on a warm summer day. So I'm sure that we're always going to be needed in providing trauma care when we need it. We may face other challenges because of the pandemic, but I think we've learned a lot during the course of this, and I think we'll probably emerge stronger and better after this pandemic. Thanks very much for your attention.
Thanks, Andrew. That was great, despite the slides.
I don't know, did you see any of them at the end?
I saw half of them. They were kind of cut off on my screen anyway.
Oh, really?
Yeah.
Okay.
I don't know if anybody attending has any questions, if they just want to type it into the chat box. I think, Dr. Beckett, thank you very much. And I think you did kind of touch on a lot of things that definitely as an RT we experienced in the beginning of the COVID, and people got caught up in the anxiety of everything and kind of forgot that we still know how to treat our patients, just how we're going to do it a little differently now. And it was easy to feed off of other people's anxiety and get yourself quite anxious over it.
Yeah, I think it's, being consistent. But I think, that it was the constant right angle of you want to speed up in trauma care and you want to slow down during the pandemic. And, every time we had a solution to do something a little bit slicker, there'd be some other concern that came up. Well, we got to wear this protective equipment now, we have to do this, and that slows things down. So, I mean, these two entities are really, they're really go against each other. So, and I think, knowing the priority is well, if we treat all our trauma patients the same as we were and expose all our staff, we could have major outbreaks of in our staff, and we could lose people. And in fact, there was a concern early on that all the trauma surgeons across the Sunnybrook and St. Michael's, we were cross-appointed to both institutions because we were afraid, well, what if all the staff at Sunnybrook go down? We're going to have to go and replace them up there, or what if we lose all our nurses in the one of the ICUs? What are we going to do? So, so protecting staff became really important because, and I'm sure you're experiencing this now in Nova Scotia, but our human resources issues now here are really bad. We're having trouble filling ICU shifts. Some of the emerge shifts are going into evening shifts, 9 nurses short, and that's one of the main impacts of the pandemic now is the loss of human resources for continued operations.
Yes, we're having similar issues here as well.
So there's a question that came in from Michael Adams. Has there been any change or challenge to the handover from EMS to the trauma bay environment?
Oh, the handovers, I think there was already a project going on in Toronto to make the handovers more standardized. I missed AMBO is one of the acronyms that we're using to hand over. But yeah, the handovers have been, very challenging because you have everybody is wearing masks, and so it's more difficult to communicate. Yeah, and I think one of the things we had to do is make it more standardized. For example, missed mechanism, injury, symptoms, treatment, because some of the usual laissez-faire handover was getting more difficult because of the PPE requirements.
Andrew, it's Rob. I have a question. You kind of finished off with saying there are a lot of things, both good and bad, that have come out of the experience with COVID. In your mind, what's kind of one of the most important things that will have a long-lasting effect on trauma care that we've learned in COVID?
I think probably one of the most long-lasting effects is the realization how fragile the system is. I think you know, the massive amount of staff turnover during the pandemic in the emergency room, we're just losing people so quickly, and I think I think we were unaware about how fragile that staffing was, and that's going to be long lasting. I think having reliable, well-trained and experienced people in the trauma bay is like you cannot replace those people. And I think with the attrition that we've seen, that's going to be long-lasting, and I'm sure you guys are well aware of that as well. And I think this is going to take us, maybe a decade to recover some of that experience, unfortunately. On some of the good sides, I think, being an academic and trauma specialist, you get addicted to the lifestyle of traveling around, going to conferences, meeting all the latest people. But in the end, one of the benefits of the pandemic is, I think many of us, like, you don't have to do that. You can watch all the stuff online, and so you don't have to travel that much. And I think probably so you're more present in your institution to look after patients. So I think that's probably one of the benefits. And I think other changes that we're going to be seeing in the pandemic is post-pandemic is with in terms of clinical benefits, is probably people are much more experienced with ECMO now, and that experience is now being used on trauma patients. So I think we're going to see that more in the future.
One other question, Andrew. You mentioned you used a video feed in the trauma room with the viewing room across the hall. Was that difficult to do? Like, that's very, very interesting.
So this was a project that had been already kind of started up for QI and research. It was a black box system. So it's multiple cameras had already been started to be set up in the trauma bay for doing research projects on team dynamics and QI type stuff. So those cameras were already being set up, and they were already getting linked up to this viewing room. So we're still not recording any of these videos for any research as of yet, because there's obviously many HR and legal issues that have to be gone through, and also REB issues for research using these systems. So but I think one of my favorite things to do there was, people would be running a trauma, and I just go down and sit in the viewing room and watch what was going on. And you get a really good sense with these black box cameras, what's happening. You would have one camera focused on the monitor, so you could actually see what's going on with the patient. You could hear pretty well what was happening, and have care of the patient. So it really gave you a good idea. And all somebody would have to do if they required anesthesia or orthopedics, they say send in orthopedics, and the orthopod would just walk into the trauma room, and it was right there. So that was just serendipitous that had already been basically set up before the start of the pandemic. I can tell you there was other events that happened that were serious. And I think with all the PPE requirements and all the extra requirements, people were getting tired, pretty quickly, and things happened, including bringing someone to the CT scanner with that as a trauma that you're worried about COVID-19, and everybody is wearing an N95 mask and goggles and gowns, and you're trying to run somebody in the scanner, and things happened, including things like as the scanner table was moving, that person got disconnected from the ventilator. So obviously that's a major event, and so things like that happened. And when you're having to work in these conditions for multiple trauma team activations, it's very hard on people, and things did happen. And I think you have to approach those incidents in a systematic way, and really go through, well, how can we do it better next time? That a checklist before the scanner starts rolling, and RTs had to be much more involved in terms of when somebody's on the vent and going for scan, and really systematically look at these events.
Any more questions? No, I don't see any more questions in the question box or the chat box either. We have the team. Thank you very much, Dr. Beckett. Greatly appreciate your time.
Okay.
Thanks.
Okay,
Andrew.
thanks so much for having me. Take care, everyone. Okay, bye. Bye.